You still have YouTube and Facebook Live?
We are live, sir. Good afternoon to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Vinay Goel. Sir is MBBS MD, DM, Chairman at the Department of Neurology, Institute of Neuroscience, Medanta, Gurgaon. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is shaking up the diagnosis, a case-based approach to juvenile monoclonus epilepsy. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you. Thank you for kind introduction. Uh, Let me share my slides. So today we are going to talk about something which is very common. We see in everyday practice. As I'm sure all of my audience right now have seen cases of epilepsy. But what is the type of epilepsy? How do you treat that? We'll have some cases and discuss accordingly. I also want people to interact in between, because if you will not interact, I will not enjoy giving this talk. Initially, I'll show you first case, which will be classic case. Then we'll see some more cases which you would like to listen to it. I bring greetings from Medanta. So this is the recent classification, 2017 classification, just to revise. When I was a student, we used to call it partial epilepsy, and then the classification changed over the period of time. And this is the most recent classification, which is 2017 ILA classification, when they divide epilepsy into focal onset, generalized onset, and unknown onset. When I say unknown onset, it means we don't know what kind of seizure they have. Focal onset can be divided into with awareness and impaired awareness. So I give an example. Patient had a jerking of right upper limb and he was fully conscious, that is with awareness. On the other patient, while working while jerking, he lapses into autosensorium. That is with impaired awareness. And that could be motor onset, meaning what I'm doing is in motor onset, or it could be non-motor onset. So it could be sensory. I may have tingling phenomena. I may have perspiration, sweating. That is autonomic, or psychic could be my behavior may change. And then I'll opt into transfer. So there could be motor, sensory, autonomic, or psychic onset. This is how the classification goes. Let's look at the first case. So this is a 14-year-old young girl. She gets early morning seizures for last 2 years. Classically, she also gets jerk. So I'll just demonstrate. When you are sitting in the morning, you are brushing, you jerk. You're holding a cup of tea and you jerk, and you drop objects. This is a very common history. Cognitive she is intact, development is intact, her birth and milestones were normal. There is a family history. Her elder brother also has a similar problem. Now, an MRI brain is normal. What is the likely diagnosis? Let's look at the next investigation will be to do an EEG. If you see this kind of EEG, as you could see up to this place, the EEG was showing normal. There is a sudden burst of abnormal discharges, which are 3 to 4 hertz. When I say 3 to 4 hertz, I mean 3 to 4 discharges like this per second. And they are symmetrical, bilateral, they're equal. To see something like this, and with the history what I have given you, I will think this is primary generalized epilepsy. Very simple. There are so many types of primary generalized epilepsy. So what will the diagnosis? Here it will be juvenile myoclonic epilepsy. Juvenile means young onset. The onset is between 8 to 18 years, but it can sometimes have later on also. Classically early morning seizure, और if you are awakened, स्कूल जाने के लिए बच्चे को उठाया, उसको दौरा पड़ गया. Early morning myoclonus, सुबह उठते ही झटके आते हैं. They may not have seizure that particular day, they may only have jerk. Then if that is the situation, then you could diagnose them as juvenile myoclonic epilepsy. Treatment is sodium valproate, which is a drug of choice, and 80 to 90% patients respond very well, even to small dose as small as 200 milligram of valproate. Problem with valproate, difficulty in giving in female because of its teratogenicity. It causes weight gain, it causes hair growth. That's another problem. Now we have newer drugs called levetiracetam, which all of you know very well, topamate or zonisamide, which can be given. In female, I would prefer to give levetiracetam. if it is a childbearing age. If somebody says, I had my two children, I've done my tubectomy, or my husband has done the vasectomy, so the family is complete, and the patient throws the seizure, I will shift back to sodium valproate. Also, sodium valproate up to 5 to 600 milligram per day is also safe in pregnancy, and the titerature anicity is very small. But why to take a chance? So I would prefer to give levetiracetam in the doses of 500 milligram BD. If they are controlled over the period of time, I will reduce the dose. How long to treat this condition? Juvenile myoclonic epilepsy has to be treated lifelong, or as long as you are aged 45 to 50 years, because the chances of getting seizure after this year decreases dramatically. Problem is during pregnancy. If you have a pregnancy, I would don't change the drug, please. If you are taking sodium valproate to drug level, repeat ultrasound 12 week and 16 week, and look for any neuroendocrine defect. Then we proceed accordingly. If everything is okay, seizures are controlled, I would not get discontinued drug. Another common problem is any kind of epilepsy. Patient is taking some drug and you get a seizure and you have a pregnancy. The first thing they do is to stop the previous drug and put them on carbamazepine. This is the worst thing you can do in any pregnant lady. If the seizures are controlled, if the drug is safe, please do not discontinue and don't be following carbamazepine. Here is the other way around. Carbamazepine, phenytoin sodium, and gabapentin. If you are giving the wrong drug, that is these three drugs, it may worsen myoclonic seizures. So these are not the drug of choice. The most is one of the commonest primary generalized epilepsy, and up to 10% of the cases will have juvenile myoclonic epilepsy. Is there any question on this? I don't see any question coming up. Let's see another case. This is a 26-year-old boy had episodic jerky movements of right side of face. He's jerking like this. And upper limb for last 6 days. And he had 2 to 10 episodes per day. So what is this? As I showed you the classification, the classical focal seizure with awareness. Last episodes were half an hour. It means the seizures are still happening and you may not know when will the next seizure. Examination is normal. Family history is not contributory. What you will do next? So diagnosis, first thing you need to know is an epileptic seizure or a non-epileptic seizure. When you will fall, you will incontinence, but in focal seizure, sometimes it is very difficult. How do I give an example? This is my seizure. So this is not jerky. Seizure is a jerky phenomena. So you will have and jerky, and there is a repetitive and there is a rhythmicity. Second thing, you could see the frequency. This is the frequency of seizure. But if I am doing this, this is not seizure. This is not jerky. This is like tremor. Or some people say, "Okay, मेरा हाथ झटके मार रहा है." So these are likely non-epileptic seizures. How will you investigate this? Whenever there is a focal seizure, first thing you need to do is imaging, whether you do the CT scan or MRI, depending on the availability of the investigation. So let's look at imaging. So look at the CT scan. What is this? So there is a ring enhancing lesion on the contralateral side in the frontal lobe. So what? Now what is the possibility? The commonest thing what we see is neurostasis, of course. Second common thing is tuberculosis. If this is a 60, 70-year-old elderly person, I would think this is metastasis. So depending on the age, you will consider differential diagnosis, and if required, you do contrast MRI, you do MRI spectroscopy, and still, if you are not sure, you repeat imaging 4 to 6 weeks after giving antiepileptic, and then look into the lesion. Why 4 to 6 weeks? Because sometimes malignancy conversion faster. So sometimes I repeat imaging after 15 days, I have a strong doubt. Then we could do biopsy and then make the final diagnosis. Will you do MRI? I think we discussed this point. How will you treat this patient lesion? If it is a neurocystic sarcoidosis, will we give antihelminthic? I'm not able to interact with the audience, so I don't know how an audience is feeling about this. But let me tell you, if you see a single lesion, please do not give antihelminthic. Please do not give albendazole. When you give albendazole, you increase chances of having seizure. You increase chances of having calcification. There are very well done studies. So avoid using albendazole in a single lesion. Whether to give steroid or not, it depends on if there is a massive edema around the lesion. You may give short course of steroid, oral steroid, and that should be good enough. When will you repeat investigation? We just discussed now. So let's look at this. This is the scan of the same patient. And after about 3 months, if you see, the lesion has significantly reduced. Edema is still persisting. You do see there is colex, there's a bright dot here, which you also seen on this imaging. I could see in my scan. So if there is an eccentric dot, then likely this is cysticercosis. Without giving any albendazole, it is significantly reduced. So just give anti-epileptic in this case. So what treatment will you give? Any kind of primary epileptic drug is good enough. Phenytoin sodium, carbamazepine, levetiracetam, clobazam is good enough. It depends what is your choice, which drug you are used to give it, and all are equally evaluated. Will you give loading dose? I told you the seizure happened last 2 hours ago. You don't know when the next seizure is coming. Maybe you prescribe the drug and say, "Ghar jaake le lena," and he will have a seizure on the road. So it would be better you load him with the drug. If you are giving levetiracetam, you can load with injectable. Phenytoin sodium, you can load with injectable. Sodium valproate, you can load with injectable. So I would prefer that I would load this patient with food, a loading dose of the drug, and then prescribe oral medication, and then allow him to go home. I think we discussed this, whether to give or not to give anti-Hillman thing. How will you treat this seizure? Because this is a symptomatic seizure. There is a lesion in the brain, and that's producing seizure. If I repeat imaging after six months, and if there is no lesion, please remember, if there is no lesion, I would gradually taper off anti-epileptics. But if there is a calcified granuloma, which happens in about 40% of the cases, then I would like to go treatment at least up to 2 years. Because when you have calcified granuloma, the chances of having recurrence of seizure are high. Whether to do CT scan or contrast CT scan, whenever there is a seizure, we have to do contrast CT scan because we are suspecting inflammation or mitotic lesion. Plain CT is best when you suspect an infarct or hemorrhage. Then you do plain CT, otherwise do contrast CT. CT or MRI, it depends what is available with you. CT scan is easy to do, it's cost effective. MRI will require time, it will take about 20 to 40 minutes. Preparation, cost, and availability of the center. So these are pros and cons of the investigation. Let's look at the third case. This is a 27-year-old boy, history of fits since 15 years of age, both sleep as well as awake, starts with blank stares. So parents are telling, whenever I'm talking to them or sitting in the class, he suddenly starts staring and does this automatic movement like this, as if he's chewing, and he's turned his face to the left. And you must ask this, where the head is turning from. Ask the parent to put the hand on the shoulder. They'll say he's turning his face to the right, but when you ask him, he'll put this hand on the shoulder. That will tell you whether it's a right-sided seizure or left-sided seizure. Now, what other history you'd like to ask? I would like to ask whether there was a similar episode in the past, whether there is a family history, whether he had any history of cystic or any tumor, any trauma in the brain. So now we know this is a classical focal seizure with impaired awareness, the classification which I showed you. Investigation, first I will do an imaging and the CT scan or to do an MRI. We discussed this point just now. Whether to do MRI with epilepsy protocol, if anybody having seizure more than 2 years, and it is not primary generalized epilepsy, you think there's focal onset, then please also do MRI with epilepsy protocol, which mainly is done to look at hippocampal atrophy, and I'll show you this. If you have suspected this, then you will require a FLAIR sequence or IR sequences. Thin coronal section, look at this. When you look at this, as you could see, this is not a very good slide, but as you could see, there is an atrophy on the left side as compared to the right side. I think this is a better picture. If you could see, let me remove this. This is the normal hippocampus. As you could see, this is the lip-shaped hippocampus. Whereas this or here, there is an atrophy. The size of the hippocampus is reduced. So this is telling me, and also you could see there is signal change. This is better picture. Look at this hippocampus, look at this is smaller in size, there is atrophy and also signal chain. The flare sequence is showing signal chain, so that tells me there is something wrong. Likely there are two pathology in middle film. I think there are two pathology. One may be mesial temporal sclerosis, or there may be associated DNET or other cortical dysplasia, which may be present in this case. We saw this. So how will you treat? We treat same way, the way we treated the second case or any of the primary drug. We talked about medication also. Would you consider surgery? So when to do surgery? Anybody is a candidate for surgery if you get 2 seizures per month on 2 optimal drugs for more than 2 years. That's a very simple calculation. If you do this, that is considered as an indication to do surgery. Then you would like to do an extensive surgical workup, which would be to do video EEG to look for whether the seizures are coming from what particular part of the brain. Good quality MRI with, if you require, you do an MR spectroscopy also to look at whether sometimes the MRI may be normal, but the spectroscopy will show there is an abnormal tissue there. And that will help you to localize. Then good quality drugs. I tell you, I have seen patients who take free drugs from some of the dispensaries outside government hospitals. When we tested when I was in AIMS, we tested these patients and we found the drug level was zero. So good quality drug is very important if you consider that this is a refractory seizure. Other things, suddenly somebody was doing well and now he gets a seizure. I always ask them, did you buy medicine from somewhere else? Or did you get medicine free from somewhere? They say, yes, last time we bought medicine which was cheaper from somewhere else. So likely this drug was spurious. He was very well controlled, and because he has now taken spurious drug, so that has precipitated seizure. So we discussed what are the points when we will consider him for surgery. And still, if somebody is getting seizure, I think it's better you can send this patient to Medanta for extensive workup. Thank you very much for patient hearing.
Thank you so much, sir, for this wonderful presentation. We do have some questions now from our audience if you'd like to take that up.
We'll be happy to do that.
So, sir, the first question is, what are the hallmark clinical features of JME and how can they be disguised from other seizure disorder?
I think I covered this question. Classical is 8 to 18 years of onset, early morning post-awakening seizures, which may be preceded by jerks. There may be only early morning jerks without seizure. This is a classical syndrome.
Next question is, sir,
And when,
how
and when, and when you do EEG, you will see classical 3 to 4 hertz discharges. So that will also confirm the diagnosis. Yes.
Thank you, sir. We have another question. How does JME impact cognition function, learning, and daily activities in adolescents and young adults?
That is a good part about JME. JME usually does not affect cognition or development or any of the social activity. Yes.
There's one last question, sir. How would you approach a case of JME in a patient with poor drug complications and recurrent seizures?
I think JME is the one epilepsy where they respond to very small dose of drug. When they respond to small dose of drug, the compliance is usually not the issue. Compliance comes because they have to take it for a long period of time. Sometimes they stop taking the drug thinking कि 5 साल से दोहरा तो हुआ ही नहीं है, डॉक्टर साहब दवा बंद नहीं कर रहे. They stop the drug and within 2 to 3 weeks they will get seizure. So if your diagnosis is JME, please do not stop medication without consulting your doctor. We usually give up to 45 to 50 years of age because after that age, the chances of getting seizure because of the JME is significantly low. That's the time we can stop the drug.
Thank you so much, sir. That's all from our audience. With your permission, I would like to conclude today's session.
Thank
Before
you for this.
concluding, sir, any take home message from your end as well?
Message for me is even this I also speak on national television. Anybody who gets a seizure more than 3 to 5 years, please consult a tertiary level hospital. Then it's the time to consult at a higher center because now you can be investigated extensively because about 15% of the patient they are not controlled on the drugs can benefit from surgery. And now there are different types of options to do surgery. We can do investigation, find out for the exact which part of the brain they are coming. We can remove that part and cure the patient forever.
Thank you